Hello everyone and welcome to our module on renal tubular acidosis. A renal tubular acidosis is a rare disorder of ion channels in the nephron, and all of the different types of renal tubular acidosis cause a non-anion gap metabolic acidosis. This means that patients with these disorders will have a pH that is below the normal range, meaning below 7.37, that's an acidosis, and because it's a metabolic acidosis, they will have a low serum bicarbonate. And often the way these disorders are identified is when routine blood work is done on a patient and it shows a low bicarbonate or an abnormal potassium, because as we will see, patients with all these disorders have some abnormality of the serum potassium. Bicarbonate is the major buffer that is found in human plasma, and the job of bicarbonate is to soak up protons so that the pH stays normal at about 7.4. So in order to excrete acid and maintain a normal bicarbonate level, the nephron has to do two things. First, it has to reabsorb all the bicarbonate that is filtered in the proximal tubule, and then it has to excrete acid in the collecting duct. So both of these processes have to work, otherwise what will happen is the serum bicarbonate level will get low and there will be an acidosis. So as we will see in the renal tubular acidoses, some of them involve this system here, others involve abnormal function of this system here, but the bottom line is the same. One of these functions of the nephron in excreting acid and reabsorbing bicarbonate becomes disrupted. The first renal tubular acidosis we'll discuss is called a type 2 or proximal RTA. It's called a proximal RTA because in this disorder there's a defect in reabsorbing bicarbonate in the proximal tubule. It's called a type 2 RTA because it was the second RTA discovered. So people with this disorder have a problem reabsorbing bicarbonate in the proximal tubule, and as a result bicarbonate gets lost in the urine. And basically the way you can think about a type 2 RTA is simply that a new steady state gets established for serum bicarbonate. So you may know that a normal serum bicarbonate is 24. In patients who have a type 2 RTA, the serum bicarbonate is reduced somewhere in the 12 to 20 range. And that's because they're losing bicarbonate in the urine, so the steady state does not settle out at 24. Instead, it settles out somewhere in the lower range. And because the plasma bicarbonate level is reduced, there's going to be a non-anion gap metabolic acidosis. And many patients who have type 2 RTAs are asymptomatic or minimally symptomatic, and that's because this reduction in the plasma bicarbonate is relatively modest and doesn't always cause severe symptoms. Some other features of type 2 RTAs are shown on this slide. Patients with proximal RTAs develop hypokalemia, and the reason this happens is because anytime you don't reabsorb bicarbonate normally in the proximal tubule, you will also reabsorb less sodium and water. Here's a slide showing the process by which bicarbonate is reabsorbed in the proximal tubule. So filtered bicarbonate enters the lumen of the nephron here, and it needs to be reabsorbed into the interstitium on this side. The way this happens is that bicarbonate combines with acid, and the enzyme carbonic anhydrase converts that into carbon dioxide and water. Carbon dioxide and water diffuse into cells, and then carbonic anhydrase converts that back into bicarbonate and acid. The acid goes out so it can be used again, and the bicarbonate is reabsorbed. In order for this whole process to work, sodium has to be reabsorbed along with bicarbonate. So what this means is in patients who have type 2 RTAs, they reabsorb less bicarbonate and more bicarbonate goes out in the urine. And in addition, they reabsorb less sodium and more sodium goes out in the urine. And sodium will take water with it, so therefore there's going to be sodium and water loss from the body. So because there's less sodium and water reabsorption, there's some volume contraction. That activates the RAS system, which increases aldosterone levels, and that promotes potassium excretion, and therefore hypokalemia develops. Another feature of type 2 RTAs is that the urine pH will be low. Now in any acidosis, there's more acid filtered into the nephron, and therefore the urinary pH should always be low in the setting of any acidosis. However, as we will see, there are some RTAs where the urine actually becomes alkaline, but that's not the case in type 2 RTAs. The reason for this is because the distal tubule here is working fine, so it excretes acid as the type 2 RTA becomes established. This means the urine will become acidic, as it should in the setting of an acidosis. Also, because the urine becomes acidic, there will be a negative urine anion gap, and I'll talk about what this means in a few slides. And then finally, because the urine is acidic, there are no kidney stones associated with type 2 RTAs. As we will see with other RTAs where the urine becomes alkaline, those patients develop lots of kidney stones. But kidney stones are not associated with type 2 RTAs, and that's because the urine pH is low. I just want to emphasize this point about the relatively mild nature of type 2 RTAs. They are milder than type 1 RTAs. In a type 2 RTA, the bicarbonate level is usually in the 12 to 20 range. And the reason it doesn't get lower than this is because those distal intercalated cells function normally and they continue to secrete acid. So if you look at this table on the slide, a normal bicarbonate level is 24. In patients with a proximal or type 2 RTA, it's usually in the range of 12 to 20. In patients with a type 1 or distal RTA, which we'll talk about in a minute, the bicarbonate level gets very low, usually under 10. And so anytime you see a board question with a very low serum bicarbonate, you should think that may be a distal or type 1 RTA. And then finally, type 4 RTAs, which we'll also talk about later, are relatively mild, just like proximal RTAs. So in real life, type 2 RTAs are very rare. What you want to know is how to recognize them in board questions. So here's an example of a sample case. The patient may have no symptoms and have routine blood work done that shows abnormal bicarbonate or potassium, or the patient could have mild weakness, and that's because of the low potassium. The bicarbonate will be mildly reduced in the 12 to 20 range. There will be hypokalemia, and the urine pH will be low. This is a case of a type 2 RTA. And the treatment, when treatment is required, is with sodium bicarbonate, which will raise the plasma bicarbonate level. Some other things to know about proximal RTAs. A proximal RTA can occur as a component of Fanconi syndrome. Fanconi syndrome is generalized failure of the proximal tubule. So in a Fanconi syndrome, not only is bicarbonate not reabsorbed as it should be by the proximal tubule, but other things are not reabsorbed. Things like phosphate and glucose and amino acids and urate and proteins. All these things can spill into the urine in someone who has Fanconi syndrome. Fanconi syndrome is uncommon, but it can occur as an inherited disease in children. There are also some drugs associated with development of a Fanconi syndrome. These are high yield to know. One of them is tenofovir, which is an HIV drug. Another one is ifosfamide, which is an alkylating agent used for treatment of cancer. Patients with multiple myeloma also are at risk for developing a type 2 RTA. Many of the light chains that develop in multiple myeloma are toxic to the proximal tubule, so this can cause an isolated type 2 RTA, or it could cause Fanconi syndrome. And it's super high yield to remember that multiple myeloma likes to affect the proximal tubule of the kidney. And then finally, in rare cases of heavy metal poisoning, you can see a type 2 RTA. It's been reported in cases of lead poisoning, cadmium poisoning, and mercury poisoning. There are two drugs you should be aware of that always cause a type 2 RTA. The first one is acetazolamide. So acetazolamide is a carbonic anhydrase inhibitor that has a weak diuretic effect, and therefore it blocks some of the sodium reabsorption in the proximal tubule, and this is going to increase the elimination of bicarbonate. So we give patients acetazolamide when we want to cause an acidosis. So for example, in patients who are ascending to high altitude, we expect that those patients are going to develop a respiratory alkalosis, so we will give them acetazolamide to cause an acidosis and offset the respiratory alkalosis. But the idea here is that what acetazolamide does is essentially cause a type 2 RTA. If we go back to this slide, acetazolamide inhibits carbonic anhydrase, which is going to disrupt this entire process of reabsorption of bicarbonate. So bicarbonate is going to go out in the urine, and less sodium is going to be reabsorbed, so there's going to be a weak diuretic effect. We don't usually use acetazolamide as a diuretic because the effect is so weak, but it is given when we want patients to excrete bicarbonate, and that's because it causes a type 2 RTA. Another drug to know about is topiramate, which is an anti-seizure drug. This drug has carbonic anhydrase inhibiting effects, and so many patients who take this drug to prevent seizures develop a renal tubular acidosis and a reduction in the plasma bicarbonate. Moving on, now let's talk about a type 1 or distal renal tubular acidosis. And this type of RTA is called distal because the problem is in the distal nephron with excretion of acid into the collecting duct. So because there's impaired excretion of acid, there's impaired acidification of the urine. This leads to a non-anion gap metabolic acidosis, just like all RTAs. There's decreased excretion of acid, which causes acidemia, and there's an increased excretion of potassium, which causes hypokalemia. So let's briefly review how acid is excreted into the urine in the collecting duct. There are two important types of cells in the collecting duct, the principal cells and the intercalated cells. And the principal cells have a sodium channel called the ENaC channel. ENaC stands for epithelial sodium channel, and this channel is activated by aldosterone, and it pulls sodium from the urine, and then sodium is reabsorbed into the interstitium. When sodium leaves the urine, it leaves behind a negative charge. Sodium is positively charged, so when you take it out, the urine becomes negatively charged, and that negative charge draws in potassium and acid. So this is one way that acid gets into the urine, is by the negative charge left behind because of sodium removal by the ENaC. Another way that acid gets into the urine is there's an ATP-driven pump for acid in the intercalated cells. And so these two mechanisms, those of the intercalated cells and the principal cells, are the major way that acid is excreted from the body. This is how most of our daily acid load gets into the urine. So if there is a problem with this system, either with the principal cell acid excretion or the intercalated cell acid excretion, what's going to happen is you're going to get a very severe acidosis because most of the acid in the body will not be excreted. In addition, there's going to be no acid in the urine, so the pH of the urine is going to climb and become alkaline. And those are two major features of a type 1 or distal RTA, is a severe acidosis and an alkaline urine. In addition, because acid is not being put into the urine, this negative charge here is going to pull exclusively potassium, and lots more potassium will be pulled into the urine. And therefore what you will see is more potassium in the urine, and therefore hypokalemia in the interstitium and in the blood. So I've summarized these points on this slide. A type 1 or distal RTA will give you a very low bicarbonate, often less than 10. Remember that normal is 24, so less than 10 is severely reduced. There will be hypokalemia, and the urine pH will be high. That's because, as we just discussed, the distal tubule cannot acidify the urine, and the urine becomes alkaline. And in fact, the diagnosis of a type 1 RTA is established if you have an alkaline urine despite a metabolic acidosis with normal kidneys. Remember, in any metabolic acidosis, the urine should be acidic as the body tries to remove acid. If the urine is alkaline, then there is a major problem with the kidneys, and that must be a type 1 RTA, because that's the only RTA that leads to alkaline pH of the urine. It's very high yield to know that patients with type 1 RTAs get chronic kidney stones. When the urine is alkaline, this leads to formation of calcium phosphate stones. In the video Nephrolithiasis, I talk about how the majority of calcium kidney stones are made up of calcium oxalate. However, in patients who have a type 1 or distal RTA, they do not get the usual calcium oxalate stones. Instead, they get calcium phosphate stones, which are the less common form of calcium kidney stones. The reason for this is because the alkaline urine precipitates stones, and for that reason, patients with distal RTAs can sometimes have bilateral kidney stones. In addition, the acidosis suppresses calcium resorption, so there's more calcium in the urine. Another thing to know about a type 1 or distal RTA is that it's horrible for your bones. Any acidosis is bad for your bones because when there is acidosis, your bones will buffer the acid in the blood and more calcium will come out of the bones. But this is especially bad in type 1 or distal RTAs because the pH can get so low due to that very low bicarbonate. So adults can develop osteoporosis, children can develop rickets and growth failure. And so, as we'll talk about later, you can treat a type 1 or distal RTA with bicarbonate, and pediatric nephrologists give lots of bicarbonate to children with this disorder, and the reason is to protect their bones and ensure that they grow normally. Type 1 or distal RTAs have many etiologies, but for your board exams, what you always want to remember is that this type of RTA is associated with autoimmune diseases like Sjogren's syndrome and rheumatoid arthritis. It's believed that because of the autoimmune effects of these diseases, there's some attack on the acid excretion in the collecting duct. Some medications are associated with distal RTAs, in particular amphotericin B, and then there are rare genetic forms that occur in children. I'll get back to a type 1 RTA in a minute, but I want to pause and talk about something called the urine anion gap first. The urine anion gap is used for the diagnosis of metabolic acidosis, and it's an evaluation of renal acid excretion. And the idea behind a urine anion gap is that in an acidosis, acid leaves the body as ammonium, which is NH4. This is one of the ways we remove protons from the body. So in order to understand this better, let's recall that there's two ways that acid leaves the body. One is as protons in the urine, and this is what's responsible for the urine pH. The other way that acid leaves the body is bound up in a molecule of NH4, which is ammonium. So our kidneys produce lots of ammonia, which is NH3, and that ammonia picks up a proton and becomes NH4, and then the NH4, which is ammonium, is what goes out in the urine. So if we didn't have ammonia, if we only had H+, we would never be able to excrete the daily acid load because you can't get much H+ out in the urine before the pH gets dangerously low. The way the body works around this problem is by producing lots of ammonia, which picks up a proton and becomes ammonium, and then we send the acid out in the urine as ammonium. So you have to understand the idea here that in an acidosis, there should be lots of ammonium in the urine carrying all that acid out of the body. So the reason we need the urine anion gap is because ammonium cannot be measured directly, so the urine anion gap is a surrogate. So if you look at the bottom of the screen, the urine anion gap is equal to the urine sodium plus the urine potassium minus the chloride. Sodium and potassium are positively charged and chloride is negatively charged. So when there's lots of ammonium going out in the urine, because ammonium is positively charged, it will bind with chloride, which is negatively charged. What this means is anytime there's lots of ammonium leaving the body, the chloride in the urine will go up. And when the chloride in the urine goes up, the urine anion gap will become negative. So to put this all together, you should have a negative urine anion gap anytime lots of acid is being excreted. And that means that in any acidosis, the urine anion gap should be negative. That's an indication that the kidneys are working, they're producing lots of ammonia, which is getting converted to ammonium, and it's all going out in the urine. So for example, in a GI metabolic acidosis, like from diarrhea, the urine anion gap becomes negative. That's because the kidneys start to excrete lots of acid as ammonium, and therefore the chloride down here goes up, and when the urine chloride concentration goes up, the urine anion gap becomes negative. And the way most people remember this is that you get a negative urine anion gap in a GI acidosis. You can also get a negative urine anion gap in a proximal or type 2 RTA. That's because in this form of acidosis, as I told you before, the problem is bicarb reabsorption, but the distal acid excretion is normal, and therefore the amount of ammonium in the urine is normal, and the urine anion gap becomes negative as it should. In a distal RTA, however, which is what we're talking about now, and also in a type 4 RTA, which we'll talk about in a minute, the urine anion gap becomes positive. And the reason for this is because in both a distal and type 4 RTA, there's a problem getting protons out into the urine and binding protons to ammonia. So the kidneys aren't excreting acid normally in the distal nephron, ammonium and chloride don't increase, and therefore the urine anion gap does not become negative because the chloride value never goes up. So this is the value of the urine anion gap. If you have a metabolic acidosis and the urine anion gap is positive, it suggests that there's a problem with acidification of the urine in the nephron, and one of these two disorders must be the diagnosis. Another diagnostic test that is sometimes used in workup of renal tubular acidosis is called the ammonium chloride challenge. So the idea here is that you give the patient ammonium chloride, and when you do this, the NH4 is going to let go of a proton, and this is going to become an acid load to the body. And if the kidneys can acidify the urine normally, then the urine pH should get low. However, in a distal RTA, the urine pH is going to remain high, and that's for the reasons I just said, because in a distal RTA, there's a problem excreting acid, and therefore the urine will be alkaline and the acid will not get excreted normally. So now that we understand about the urine anion gap and the ammonium chloride challenge, let's go back to discussing a type 1 or distal RTA, and let's talk about what a classic case would look like. So it's probably going to be a patient with some autoimmune disease like Sjogren's disease. The patient may have a history of recurrent kidney stones, possibly bilateral stones. The bicarbonate will be very low on blood work and there will be hypokalemia, and then the urine pH will be high. And this is hugely important because only in a distal RTA is the urine pH high. In addition, the urine anion gap is going to be positive, and if you give the patient an ammonium chloride challenge, the urine will remain alkaline with a high pH. And the treatment of this type of RTA, similar to the type 2 RTAs, is with sodium bicarbonate to raise the pH of the plasma. Our final renal tubular acidosis is a type 4 RTA. And the main thing you want to remember about this type of RTA is that its major feature is hyperkalemia. This is the only RTA associated with hyperkalemia, and in fact, high potassium is what causes this RTA. Any patient who has hyperkalemia is going to develop this form of renal tubular acidosis. So the idea behind a type 4 RTA is that proximal tubular cells normally produce ammonia, which is NH3. And then as we discussed before, ammonia picks up a proton and becomes NH4 ammonium, and that ammonium carries acid out in the urine. Well, it turns out that these proximal tubular cells are very sensitive to potassium. So when the potassium gets high, these cells stop making ammonia normally, and there's a decrease in ammonia production. And when you don't have a lot of ammonia around, then you can't carry the normal acid load out in the urine, because as we talked about before, ammonium is one of the major ways acid leaves the body. The pH of the urine will still be low, however, because in the distal cells, you can still push those protons into the urine. There's no problem with that. So they will go into the urine and the urine pH will become low, but the problem is there won't be enough NH3 around to pick up additional protons, and therefore you won't be able to excrete the daily acid load, and that will lead to an acidosis. So the big picture here of type 4 RTA is hyperkalemia is the source of the problem. It decreases ammonium excretion from the urine, and this leads to usually a mild non-anion gap metabolic acidosis. So a normal bicarb is 24, and the bicarb in a type 4 RTA is typically around 17 or so. And you see these patients all the time, but you probably don't notice them because you're focused on the potassium. So when a patient has hyperkalemia, that is life-threatening, so it's treated immediately, and you probably don't notice that those patients also have a slightly low bicarb. But the reason their bicarb is low is because the hyperkalemia is causing a type 4 RTA. And when you treat the hyperkalemia, the type 4 RTA goes away. If we go back to this slide, remember that I told you that the urine anion gap is positive in a distal RTA, but also a type 4 RTA. And the reason it's positive in a type 4 RTA is because, as we just discussed, there is not the normal amount of ammonium in the urine, and the urine anion gap is a surrogate for ammonium. So when you have decreased ammonium levels in the urine, the chloride level does not go up as it should in an acidosis, and the urine anion gap will be positive. So why do patients get type 4 RTAs? Well, remember that one of the major effects of aldosterone is to cause potassium to go out in the urine. So if you have hypoaldosteronism for any reason, that will lead to elevated potassium, and that could cause a type 4 RTA. And it turns out there are certain types of patients who often develop what's known as hyporeninemic hypoaldosteronism. These patients have low renin activity for some reason, and that decreases aldosterone production, which leads to hyperkalemia. This commonly happens to diabetics for reasons that are unclear. They have impaired renin production. It can also happen in patients who are taking lots of NSAIDs. They have impaired renin release. And there are other drugs that are associated with hyporeninemic hypoaldosteronism, and any of these can lead to hyperkalemia. So some of the classic drugs that decrease aldosterone levels are drugs that interfere with the RAS. So for example, ACE inhibitors, ARBs, direct renin inhibitors like aliskiren, all of these drugs blunt the effects of aldosterone in some way, and therefore they can cause hyperkalemia. And so in a patient on one of these drugs who presents with an elevated potassium, you will probably back off on the drug to lower the potassium. But before you do that, if you look at the bicarbonate, you'll see that it's probably a little bit reduced, and that's because of a type 4 RTA. And then finally, there are some patients who are resistant to aldosterone effects. So these patients don't have hypoaldosteronism. They're just not responding to aldosterone normally. Usually this is caused by drugs that can inhibit tubular function and blunt the ability to respond to aldosterone. In particular, potassium-sparing diuretics directly interfere with the ability of aldosterone to act on the nephron, so those drugs can cause a type 4 RTA. And Bactrim has also been described as an antibiotic that's associated with aldosterone resistance. So the classic case of a type 4 RTA is probably going to be a diabetic who has some renal insufficiency at baseline, and this patient has unexplained hyperkalemia. What's happening here is this patient has hyporeninemic hypoaldosteronism. The diabetes is suppressing renin production, plus they have some baseline kidney insufficiency, so they don't make renin normally as the kidneys should. And this is going to lead to hyperkalemia, and that will suppress ammoniogenesis and lead to a type 4 RTA as we described. The treatment is usually aimed at the potassium. That's usually the main thing people are focused on when they're treating. Sometimes in patients who have persistent hyporeninemic hypoaldosteronism associated with diabetes, fludrocortisone can be used. Fludrocortisone is a drug that's a mineralocorticoid. It has a similar structure to aldosterone, and it can replace some of those aldosterone effects. So we'll finish with this summary slide of the three types of RTA. So a type 1 RTA is the distal RTA. This is the only one with an alkaline, high urine pH. Remember, these patients get kidney stones, and they can have a very low bicarb. Type 2 is the proximal RTA. This is a problem reabsorbing bicarb. It causes a mild acidosis, and it can be associated with Fanconi syndrome, where there's generalized dysfunction of the proximal tubular cells. And then a type 4 we just discussed. This is a problem of hyperkalemia. It's often associated with low aldosterone effects, and the problem here is excreting ammonium from the body. And then at the bottom of the slide, I've summarized the three RTAs and the plasma potassium and the urine pH. So the plasma potassium is only high in a type 4 RTA. The other two RTAs are associated with low potassium. And the urine pH is only high in a distal type 1 RTA. In the other two RTAs, the pH of the urine will be low, as it should in the setting of an acidosis. And that concludes our video on renal tubular acidosis.